I actually don't know what the rest of the agenda was. I'd be kind of curious to know what else was covered today. But I'm going to talk about health insurance exchanges, and perhaps I should say something about AEI, so you know where I'm coming from. AEI is a think tank in Washington. We're market-oriented, which does not mean Republican and Democrat. And I would say that there are only a few what I would call full-service think tanks in town. Brookings is another one. And I would say that Brookings and AEI are sort of equidistant from some sort of psychological political center. And in fact, we've worked together on a regular basis. And not only that, but ever since we moved a few years ago, we're now in the same block. We're separated by one building, and not coincidentally, it's the Carnegie Institute for War and Peace. So, something right about that. I don't exactly know what. I should point out the ACA did fundamentally change the way health insurance is sold in this country, and in many ways, it did some really great things. I think one of the most important social goals, which is not going to be overturned no matter what anybody may say on TV, is this idea that people should have access to health insurance, regardless of their pre-existing conditions or anything else. It doesn't necessarily mean they're going to buy it. Doesn't necessarily mean they're going to be subsidized, but they should be offered the coverage, and then if they don't like the coverage, they don't want to spend the money, or whatever the reason may be, including it's a male, age mid-20s, who is invincible. Those are all good reasons not to buy insurance. Some of them are better reasons than others. Invincibility is not one of them. So I'm not going to dwell on the good things that it did. I'm going to dwell on the things that didn't quite work out. And this is typical of legislation, federal legislation. Laws are written in a way that is really kind of an outline to what is actually intended. Now, the people who are writing these bills are spending an awful lot of time. They're very smart people. They're doing a lot of work. But nonetheless, a lot of what goes on happens after the legislation is passed, and where that happens is in implementation. A lot depends on how, if it's healthcare, it's usually HHS, or maybe it's the Treasury Department, how they interpret whatever the law says, they issue regulations and so on. And then in particular with regard to the ACA and exchanges, of course, the states had a big hand in this. Some states, I'm from Maryland. Maryland had a resounding failure for a couple of years with its state-controlled exchange. Other states did better. Maryland had the disadvantage of hiring former federal employees who worked on the legislation, and they had theories, but they didn't really know how to get it off the ground, and neither did anybody else in Maryland. But in other states, the exchanges worked out pretty well initially, and then, of course, there are federal exchanges. So it's really, you have the law, but then you have to deal with how the agencies interpret the law, both at the federal level and at the state level, and that includes insurance commissioners. And then finally, how does it actually work out in the end? So we're going to talk about all of those sorts of things to some extent. So this is something like an outline of a talk that I could give. And by the way, since this is apparently this is a credit course, I have you're going to have three questions you're going to have to answer. And I'm going to make sure that you're going to answer them right. And I might even give you a hint about what those questions may be, but, I'll give it 15, 20 seconds, we'll see. So anyway, we're going to talk about, basically how the exchanges work, the policy changes that occurred after the ACA was enacted, and then to some extent, what does anybody see for the future? And by the way, if anybody has any questions or want to raise an issue or whatever, I'm being unclear, don't hesitate to just speak right up, because it's more interesting for me, and it's probably more interesting and more informative for you as well. So, eligibility. So the ACA, the Affordable Care Act, I do not call it Obamacare, because if I called it Obamacare, then I'd have to call something that hasn't been passed Trump Care, and I don't like either term. So the ACA, the Affordable Care Act, it was passed in 2010. The first open enrollment period was in the fall of 2013 for coverage that was effective January 1st or thereabouts 2014. So who is eligible for this coverage? Well, the answer is that if you had access to employer-sponsored coverage, you are not eligible. If you were a Medicare beneficiary, you are not eligible, but you'd be crazy to want to be eligible, and so on. The eligibility basically depended on whether you had access to coverage somewhere else, and if you didn't, then you might be eligible for private plans on the exchange, or you might be eligible for Medicaid. A lot of people who are lower income people don't necessarily know that they're eligible for Medicaid. And so one of the features of the ACA exchanges, all of them, including the state ones that finally got up and running, basically they first did like a basic check of your income, how many people in your family, and so on, to get a rough idea about whether you would be eligible for Medicaid. And if you looked like you were going to be eligible for Medicaid, you were directed in the Medicaid direction. And so a lot of people moved to Medicaid thinking that they were going to sign up for these private plans in the exchanges, but they moved there because they were eligible for Medicaid, and in fact, by and large, it was a better deal for them. No premiums, little or no cost-sharing requirements. So that was a smart thing to do as far as the implementation was concerned. Now, there were, of course, subsidies involved, a series of different subsidies. The ones I'll focus on are the premium subsidies and the cost-sharing reduction subsidies. So first of all, the premium subsidies, the easiest thing to think of. Basically, what the ACA realized, or what the framers of the ACA realized, that this is really a program aimed at lower income people, say lower middle class and lower incomes below middle class, wherever that is. And so they recognized that a lot of those folks would not be able to afford the premiums, or at least the full premiums for insurance. Now, this was, by the way, the law was written before anybody knew what the premiums were going to be. So they tried to anticipate where the problem was going to be, where the financing problem was going to be. So again, I'm very sympathetic to the drafters of the bill, because you have a hard time guessing how things are going to really work out. They didn't necessarily work out the way that they were planned. So the premium subsidies go from 100% of the poverty line to 400% of the poverty line. For a family of four, the poverty line is about, I think, $50,000 or $55,000. So what about below 100% of poverty? Why didn't they get a premium subsidy? Well, this is something about how legislation is written. The original draft of this bill assumed that Medicaid would expand uniformly to 100% of poverty, and that the ACA would pick up people from 100 on up to 400, and then they were a little fuzzy about what happened after that, very fuzzy. But as the law actually passed, the Supreme Court said that the penalty for states not expanding their Medicaid coverage to what turned out to be 138% of poverty, that's what the Obama administration wanted, as it turned out, not 100, 138. But the penalty was that if a state did not expand all the way to 138, and this primarily affected adult males who didn't have child-caring responsibilities or so on, then they would lose all of their federal Medicaid money. Now, that seems a little severe, given that the male population that was below 138% of poverty that was not eligible for Medicaid was a pretty small number of people. But the people who wrote the ACA thought, we're going to make it so tough that, even those conservative states would just be forced to do it. The Supreme Court said no, that's unreasonable. That penalty can't be maintained constitutionally. And so that meant that the states had the option whether they expanded or not. Initially, something like 25 or 30 states expanded to the extent that they weren't already there. They expanded their eligibility. And again, it was males up to 138% of poverty. But there were probably 19 or 20 states that did not immediately do that. This has obviously led to some complications because it's no longer the uniform program that, again, the drafters thought they were going to have. They wanted a uniform program where people would kind of know, no matter what state they were in, whether they were eligible for Medicaid or something else. The drafters were wrong about that. It's almost impossible to know whether you're eligible for Medicaid until someone associated with that eligibility process asks you a lot of questions that you never would have thought of, and then tells you whether you're eligible for Medicaid or not. And by the same token, the ACA, the private plan aspect of it, are you eligible for a subsidy? Well, again, that's not an easy question to answer, so you have to go through the enrollment process to find out. And in the end, people went through the process, and then they didn't necessarily buy the coverage. But a lot of people did. Okay, so now let's see. I think I covered one important question. You might just keep this in mind, that it was people who are eligible for premium subsidies under the ACA, it's between 100 and 400% of the poverty line. That might be an important thing to remember. Okay, now, the subsidy structure. Design options. What I really have in mind there is what kinds of insurance plans could be offered on the exchanges. And the answer is, well, they had to cover what are called essential health benefits, some of which are maybe not all that essential, but the basic comprehensive coverage that everybody in this room has, I'm talking about the basic part of it, covers doctor's visits, covers hospitalization, covers drugs to some extent. That's what people want for health insurance. That was essentially what they were aiming at. They added a bunch of other things that probably were more political in nature, but that's the kind of coverage people want. And if you're not offering that kind of coverage at a price that is affordable, and with deductibles and cost sharing that are affordable, then people aren't going to buy it. And so what happened? Well, the answer is that the plans, the so-called silver plans, there were several rankings of plans, bronze, silver, gold. The silver plans were meant to be sort of the basic good comprehensive plans. The levels are determined by so-called actuarial value. We will not discuss that, but basically it kind of describes the breadth of coverage in financial terms. So silver plans is what people were being aimed at, and the subsidies were tied to the second lowest cost silver plan in your area, wherever you happen to live. Obviously, if you live in an expensive state or in an expensive city, the health plans are going to have higher premiums. But if you live in a place that's cheaper, where healthcare is less expensive, then the premiums are going to be lower. So the subsidy goes up and down depending on what the second lowest cost silver plan premium would be. It does make a lot of sense. On the other hand, it does reinforce that the expensive places get more money and the less expensive places get less money. So you could see that there's a bit of a policy problem there about how to deal with things. But if you're just thinking about the short term, how do we get people covered? The answer is that's not a bad approach. You have to think a lot harder if you're worried about also trying to get the health system to be more efficient and try to reduce unnecessary spending, both by the federal government and by individuals themselves. Okay, so you have this structure of premium subsidies available to people between 100 and 400% of poverty. Obviously, if you're at $3.99, forget it. It's 50 cents or something. It's close to zero. If you're at 100%, you have the highest possible premium subsidy, But again, it's hard to characterize because it's tied to the cost of the insurance. Then cost-sharing reductions. Again, they realize that low-income people cannot really come up with the money for a substantial deductible, for example. And so these cost-sharing reductions were required by law to be granted by the insurance companies. And again, it's on a sliding scale related to income, but they were available to people on the exchange in silver plans between 100 and 250% of poverty. So again, if you're at 249, you're not going to get much savings that way. But if you're at 100, you're going to get substantial savings. And again, that makes a certain amount of sense when you think about what people can afford at such a low level of income in most places. Okay, now, that was a requirement on insurance companies. One of the big political battles was that this bill was pushed through so fast because Democrats were worried that and they were right to worry, that they were going to lose control of the Senate because Ted Kennedy had died and there was an election, not part of the regular cycle of elections, and it turned out that a Republican won. He's gone now, but he won, and so they didn't clean up a little problem with cost-sharing reduction payments, which is that they have to be appropriated by Congress, and you can do that with one sentence, and it's regularly done. If you reread your legislation, you throw that sentence in, you got it. Well, they didn't do it. They couldn't make the correction because if they brought it back up, then it would open up the political doors to making other changes that Democrats didn't want to make. That left a political dilemma and a legal dilemma. Does Congress have to appropriate money for the executive branch to spend it? The answer is the Constitution says so. But just because the Constitution says so doesn't mean we have to follow that rule, do we? I mean, it's such an old piece of paper. Anyway, that's been an issue for ever since the plans really got started and people realized that there was an issue here. Okay, now let's see, have I missed anything? Okay, so then policy changes, we'll talk about that later. I have an actual slide on policy changes. Okay, one of the interesting things about what has happened since the 2014 plan year is how the premiums changed, how the average premiums changed, and what happened to enrollment. And one of the interesting facts that I don't think was very well understood, I don't think it could have been understood when the law was being written. I'm certain it wasn't understood by most people, even when it was happening, was that if you had a situation where there was additional cost in the system that hadn't been anticipated, driving up the cost of premiums, that as long as it raised the price of the second lowest cost silver plan, the premium subsidies went up. As I said, premium subsidies tied to the second lowest cost silver plan in your area. So if that plan goes up in premiums, then the subsidies go up dollar for dollar. So as long as you stay with the second lowest cost silver plan, which might not be the same plan you had last year, so you have to make sure that you're staying with that plan. But if you do, then no matter what happens to premiums, if you're getting a subsidy, then the premium you paid last year is the same dollar amount that you're going to pay this year. And it's going to be the same next year as well. I don't know that they realized that that's what they had done, but that's exactly what they did. And that has created stability in this marketplace that I think most people did not anticipate, Republicans or Democrats. So what have we seen? Well, for the first couple of years, the plans had no idea who their customers were. Blue Cross in most states is, you tend to think of the Blue Cross plan as the one that picks up people who don't have employer coverage. Of course, Blue Cross sells other kinds of plans, but people tend to think that way. Well, even where that was true, in the states where that was true, the people who were signing up for exchange plans were not in the Blue Cross system at all. They were either uninsured or maybe they were in Medicaid and they were trying to get out of the Medicaid program or other circumstances. And furthermore, a lot of them would have been excluded because of pre-existing conditions or some of the services that would have been most appropriate for that pre-existing condition would have been excluded, so they didn't sign up. So here are all these people coming in now into this program that previously weren't there, and the plans actually had no idea what they were doing. They certainly didn't know the first year because they had zero experience. They didn't know the second year because they had almost zero experience. They had maybe 1 quarter's worth of bills that had actually gone through the system enough to be pretty sure that they were actually going to pay those bills. But they really didn't know. So that's the 2014 plan year, the 2015 plan year. They basically had no clue. The 2016 plan year, which were the premiums were presented in 2015, in the fall of 2015. They were still not entirely clear, but there was a lot of political pressure to not raise your premiums. President Obama was still president. Democrats were still a very strong force. It wasn't a good idea to cross a strong president. And so premiums didn't rise very rapidly over the first few years. Let's see if, actually I've forgotten whether I have a slide that actually shows the premium increases. Do I? Probably somewhere. Yeah, well, we're just going to skip to the end and then we're going to come back. Okay. You know, I knew it was in here somewhere. Okay, so the premium increases prior to the 2017 plan year were, you know, probably 8 to 10% on average nationally. You probably saw in your own states all kinds of coverage about extremely high premium growth from one year to the next in all of the years. That is simply explained by the fact that every reporter looks for the outliers. They don't look for the average. They don't know what the average is. And it's beneficial to the state insurance commissioner to be able to say that, yes, they asked for a 20% increase, but we knocked them down to 10%. 10% being the reasonable number, or the seemingly reasonable number. However, what about 2017? So these are the premiums that were presented in the fall of 2016. Why did they go up by 25% nationally? And that's, again, that's an average. Well, the reason is political. That was the last year that Obama was going to be president. There was an anticipation that Hillary Clinton was going to be president next time around, and she certainly was going to put up with gigantic increases. And basically, by this time, the insurance companies had all the data in the world to know that they were losing money relative to their anticipated revenues, and relative to, you know, these are all publicly traded companies, so relative to the promises made to the people who actually own the company, the stockholders, they needed to reset the base. This was going to be the year they could reset the base. So they did. Virtually all of them reset the base. Average increase nationally, 25%. But what happened to enrollment? The answer is enrollment dropped a little bit, but not very much. 500,000 is, you know, what is that? That's about a 4% reduction. That's not a big drop in enrollment. And you see that we saw another big increase from 2017 to 2018. Now, why is that? Well, the answer is that Hillary Clinton wasn't elected president. So the entire insurance industry got nervous about this, and then Donald Trump was rattling that saber about cost-sharing reductions. He wasn't going to pay them. And I'll go back to that in a second. So what do? You protect yourself. You raise your premiums because you might not be able to get another premium increase. You don't know. And you put a lot of money into getting into markets that you were not in before. That is an investment. And who knows, you know, if things went south, maybe your opportunity to make good on the investment that you'd been making for quite a few years, basically since 2010, might terminate in 2017 or 2018. You just weren't too sure. But what happened? Well, enrollment dropped by, again, another about 4%, not very much. And who were they? They were people who weren't eligible for premium subsidies by and large. It was largely those people who got premium subsidies stayed in the market. So in that sense, the exchange market is really, really quite stable in that sense. Okay, so let's go back to where I was and see if I had anything interesting to say. I don't know. Whoop. Okay. So this illustrates that point about the change in the unsubsidized share. Let's see. This is a little too hard to explain, except it gives me an excuse to explain about silver loading, which is another important aspect of this. As I indicated before, subsidies are tied to the cost of a silver plan. When times got tough, and particularly for the 2017 plan year increase, we were seeing 25% increases. And by the way, 25% is an average, so some plans went up by a lot more than that. Some plans went up by less than that, but not a huge amount less. We were not seeing single-digit increases for 2017. And so there was a lot of noise, a lot of political noise about that. And some smart states and a lot of smart insurers said, well, why don't we just raise our rates for the silver plans? We don't have to raise the rates that much for the bronze plans or the gold plans. Let's raise the rates for the silver plans. That'll drive up the subsidies. And lo and behold, everybody's going to be okay. The insurance plans are going to be okay. The people buying the coverage are going to be okay. The only person who's not going to be okay is going to be the taxpayer who's going to pay a lot more. And because of the premium subsidies. Now, some states were dumb. And they either said, no, we're not going to allow you to do that because they didn't understand the rules, or in some cases, I think it was a political stance. And the net result was that in those states, there was a much greater loss of coverage in general because all the rates went up by a very substantial amount. However, by the time we got to the 2018 plan year, in other words, the premiums offered in the fall of 2017, pretty much all the states finally figured out that that's what you need to do. You need to take advantage of the federal rules as they are. Let the federal government pay. By the way, that would be us, taxpayers, but people don't think of it that way. So as I say, it's a fairly stable situation, except for people who don't receive premium subsidies. And so the net result is that you see a very substantial reduction in insurance in people who are on off-exchange plans. Now, these are people who are only buying individual coverage. They're not getting coverage through Medicaid or Medicare. They're not getting coverage through an employer. They're buying their own. And you can see that that's a very substantial reduction in participation in plans in the off-exchange individual market. And, offset somewhat by these other adjustments. What that says is that this is where people went if they weren't eligible for premium subsidies. And they went there hoping that they would find coverage they could afford. And several million found coverage that they couldn't afford. And part of it was because they had to cover the same so-called essential health benefits. But there were a lot of other reasons that went into this. And it wasn't just premiums. It was also the deductible. Silver plans typically have deductibles $5,000, $6,000, $7,000. Well, if you're a low-income person, you don't have that kind of money. And if you're not eligible for cost-sharing reduction payments and very generous cost-sharing reduction payments, you also don't have that kind of money. So would you buy that coverage? No. You'd take your chances. Now, if you're lower middle class, it's really a pretty good bet. If you're basically healthy, this is especially true if you're single. If you have a family, it's much harder, as you know. But if you're a single person, male or female, it doesn't matter. If you delay buying coverage for 1 year, you're likely to save $7,000 or $8,000. And if you don't get sick, that's savings. Now, what about that evil mandate penalty? Well, the answer is that for the first year, nobody knew what it was. Because how do you find out about these things? You don't find out about it as a human being, as opposed to somebody who lives in Washington, you don't find out about it by reading the law. You don't find out about it by reading a newspaper. You don't get that far in the paper. That's buried on page 15, if it's there at all. You find out about it by asking your neighbor. And your neighbor says, huh? Exactly. So for the first year, even though there was theoretically a penalty, it was as good as nothing. Now, had they been able to figure out a way to make it real the first year, it still wouldn't have worked because they didn't want to charge people too much money. Again, low-income people, but a couple $100 doesn't do it compared to saving for a single individual $6,000. And then on top of that, you get coverage that you basically don't want. And it's not that you don't want the benefits, it's that you don't want the $5,000 deductible. So you've got this constellation of things that didn't go right because some people, very smart people, with brilliant ideas, getting advice from all sorts of people who have their own financial interest at stake, put something together that basically didn't think about how you run an insurance business in this income sector of the economy. Believe me, it's a hard sector, hard to do. Let's see, I probably have to cover some other important question here. Let me see if I hit it yet. Okay, no, I haven't hit it yet. Okay, good. Okay, so then, how were the rules interpreted? What have we seen develop since, well, especially since the Trump administration came on board, but even before that? We've seen a number of initiatives advanced by the Trump administration of association health plans, which I can explain in just a second, short-term limited duration plans, health reimbursement arrangements. These are all generally ideas that might give somebody an option that might be cheaper, but it also means that it's not going to have the breadth of coverage that ACA plans have. Now, some people who are not analysts will say this was sabotage, that the Trump administration was trying to undercut the ACA. However, the data demonstrate that nothing was undercut, so probably that wasn't correct. And maybe people in the White House actually thought they were sabotaging something. But if they did think that, it didn't work. I think a smarter way to think about this is that there are an awful lot of these lower middle class people who really were caught between a program that was not aimed at them and the rest of health insurance, which was also not aimed at them. They couldn't afford either one. And so I think the idea behind these proposals was, well, maybe there's some way to create an insurance miracle by having insurance that people actually want that's actually cheaper than you can get on the exchanges for people who aren't eligible for subsidies. It's not entirely clear that works, but I think that was the intention. And this is especially important in states that are more agrarian, because states that have a lot of farming or ranching typically don't have big companies that employ millions of people. It's the big companies that offer good coverage. The corner store does not offer good coverage. Farmers buy their own. And so really, this was aimed at, I would call, it's kind of the Midwest and the Great Plains. That's where they needed the most help. We don't know yet whether this has worked out very well, but the fact is you don't get the same coverage, but it could be cheaper. I'm not sure how much time I have here. Okay, if you want me to explain something in this chart, just let me know later. But let me get past this. I've been talking too much, and I want to get you people to talk. Now let's see. Okay, so all right, I want to make sure that this is another important question, which I sort of already addressed, but I'm going to have to repeat it because you never know, and I'm not repeating it exactly the way you'll see it. But anyway, cost sharing, wait a minute. Oh, no, I'll do it here. Oh, okay. So cost sharing, reduction payments, and other things also changed. Let's see. Here's the sabotage one. So Donald Trump, what's kind of interesting, most people think that he doesn't have much respect for the Constitution, and he doesn't know much about the rules of government. And I might even share that view. But oddly, on cost-sharing reduction payments, he actually adhered to what the Constitution said. And he actually pushed hard. If you read some of the speeches and some of the other things that were put out by the administration in 2017, it was completely clear, both coming out of HHS and out of the White House. They really wanted Congress to pass a law that paid these things. Because if you didn't pay the payments to the insurance companies, they were still on the hook for something like $7 billion worth of cost-sharing payments. That's a lot of money. That's a 10-year number, but that's still a lot of money. So you've imposed a requirement on insurance companies, but they can't recoup it. And it's a reasonable social goal. Everybody, I think, would agree that whether the mechanism was great or not, the idea of making it easier for people to cover that cost-sharing requirement makes sense if we're talking about low-income people. He had quite a few statements basically saying Congress got to work. What did they do? They didn't. And so in October of 18, finally he had enough. He suspended the cost-sharing reduction payments. That led to the silver plan, the silver loading phenomenon. What it proved was that it wasn't the mandate that made the program work. It really wasn't extra payments to insurance companies that made the program work. It was premium subsidies tied to the cost of insurance that made the program work. And as long as you only wanted to make sure that people between 100% of poverty and somewhat less than 400% of poverty were going to be covered, or at least would have no excuse for not being covered, then you're okay. As long as you're willing to say, don't care about people between, let's say, 350 and 500% of poverty, which is kind of middle class there. The fact is that what Trump said he was trying to do, basically, he claimed he was going to undercut the ACA, but in reality didn't undercut the ACA because the private sector is smarter than the average politician, and they figured out how the subsidies worked, and they also figured out ways to structure their plans so that they could stay in the market. And they also realized that there's some markets where it was a mistake to be in. So when you saw plans dropping out of certain markets, over the second year, the third year, the fourth year, what were they doing? They were saying, we tried this. It doesn't work. It's too much effort to try to get too few people into a plan that they don't want. So we're going to focus in the areas where we already are. The big insurers, not surprisingly, tend to sell plans where there are big employers and where there are big cities. So they stayed in those markets. And why did they stay in those markets? Because they already had networks. They didn't have to create new networks. They had to make new deals, but they didn't have to create new networks. If you have to create a new network, you're talking about probably at least a 5-year development process. It's incredibly expensive, and you probably don't break even for another 5 years. In other words, the ACA, for political reasons, insurers went into markets that they didn't belong. They pulled out. That was inevitable, and not being undercut by anything other than reality. What about the mandate penalty? Well, it was repealed. Did a normal human being pay any attention to it? I don't think so. Because by 2019, nobody was paying any attention to it anyway. And there was a considerable question about who was paying the penalty. IRS religiously put out information indicating that several 100,000 people were actually paying the penalty. My guess is that they were using TurboTax. It charged them. They had no idea that they were paying it. It was too complicated. They paid it. It wasn't people who were saying, I better pay this because somebody's going to come after me because I didn't get health insurance. It was probably more accidental because life tends to be accidental, not planned. Okay. So anyway, let's see. What else should I say here? So I think the big issue here about what happened, I think this slide represents this. What happened when CSR payments were halted? The answer is that people who were not eligible for subsidies of any sort tended to leave that market. But people who are eligible for subsidies basically stayed right there. And the departures were so modest compared to the total numbers. That's, 400,000 compared to drop from 18 to 19 compared to 11 million people. That's a really modest decline in any market. So it's pretty clear that people who were eligible for subsidies stayed in the plans. People who didn't get subsidies left. They didn't get more people in, but it was stable. Okay, and then finally, let's see if I have this one. Oh yeah, I should have mentioned this up front. And I mentioned this out of order because, you might need to know this, but it's pretty obvious. So who can enroll in an ACA exchange plan? Could it be anybody in this country? The answer is no. You have to be a citizen. A lot of the talk about Medicare for all these days, you have Democrats saying we got to get everybody insured, but President Obama said no. We're going to insure people who are here legally, not people who are not here legally. You have to have legal status in order to be covered under the ACA. So it's not everybody. It's people who are legal U.S. residents. But also, you can't sign up for an ACA exchange plan if you're eligible for Medicaid because you're automatically shunted over there. So it's not everybody. It's basically the target group is citizens, lower income people who are not eligible for Medicaid. Okay. Now, what about the future of the exchange market? I think that's an interesting question because, in my view, this is a completely stable situation. Now, you'll hear people say it's unstable, and what they mean is that low-income people have not increased their enrollment in these plans. But when you look at the mechanisms, you can see why that's the case. Unless there's a change in law that broadens access to the subsidies or changes the rules with regard to cost-sharing requirements, you're probably not going to see a substantial increase in enrollment, no matter what anybody does, because in the end, if the coverage doesn't look good to people, they're not going to buy it. In fact, what did the mandate actually do? I think the mandate did have a useful purpose probably for the first year. It did two things. One is it got every newspaper and television program in the country 24 hours a day, every 5 minutes, telling you there's a mandate, you better buy insurance. That was a good thing. It got a few people, including that guy in his early 20s or late teens who not on his parents' plan, who was never going to buy insurance, to feel a little bad when he didn't buy insurance. He just still didn't buy it, but made him feel a little bit bad, worse. But it really did open the eyes of people. And what it also did for people who are actually eligible for Medicaid was it, in a sense, gave them permission to see whether this is something they could do. And even better, the door was not through the Medicaid door. The door was through the exchange program. So they didn't have that welfare stigma. That was, I think this was largely accidental. This was not all that planned, but it turned out to have a very good effect because a lot of people ended up enrolling in Medicaid who might not have asked unless they were dragged into the hospital through the emergency room. So we've got a very stable program in that sense. And the question is, well, could there be other changes in law that could affect the ACA in any substantial way? And leaving aside fantasies on the left and the right, what are the practical things that could affect this? Well, I think one of the things that could affect this would be to finally appropriate money to pay the cost-sharing reduction payments. And even though I'm saying that this is a stable situation, it's not a preferable situation. It is much better if the government is going to impose a requirement on someone, either an individual or business, going to say you're going to have to spend your money to do something that we want done. Then the government really has an obligation to pay for it. Especially in this case, because we're talking basically about an income transfer from higher income people to lower income people through insurance companies. Well, that's about the most inefficient way you can imagine of transferring income to anybody. Because, first of all, a lot of people don't even know they got a break. And second of all, there's some administrative costs associated with doing all of that. It's not a very smart thing to do, but that's what they did. So paying the cost-sharing reduction payments would have a positive effect in the following sense. As long as insurance commissioners in the states were awake this time and did what they're supposed to do, which is to tell the insurance companies when they come in for their first discussion about what their premiums are going to be, no, they're not going to be that high. We're not going to allow you to have that kind of an increase because now there's a new change in circumstances. You're now getting paid for that, and so you're going to have to cut your fees. We want the premiums to go down. And along with premiums going down, we'd really like to see that deductible go down to some extent. But we want to see it come down because if we're going to give you money, you're going to have to give it back in terms of a more appealing product. And if you do that, you might attract more people. Now, the problem with all of this is that we're talking about a population that doesn't have much money, and we're talking about health benefits, which are expensive if you're getting the kind of comprehensive coverage that most people want. And again, I'm not talking about exotic things. I'm just talking about hospitalization, doctors, lab tests, maybe some limitations on there, drugs, maybe some limitations on there. I'm not talking about something that millionaires or politicians. Well, no, that's unfair. But I'm not talking about really exotic issues. I'm not talking about the sort of thing that everybody thinks is normal, but is not normal in the individual market. And so I don't see cost-sharing reduction payments being made. I don't see any movement, at least for the next 2 years. After that, there's an election, and who knows? It's pretty clear to me the Democrats are not interested in doing little fixes, even though there are a whole bunch of things that they didn't mention that really should have been fixed in 2010 and weren't. But if Democrats win the White House and sweep the Senate and hold the House, in 2021, will they be looking at this? I wouldn't bet on it. Because in a sense, it's old news. And politicians only respond to something that they can claim credit for. So they're going to invent something else. I don't know what it is, but they're going to invent something else. And it's going to be great. Anyway, I want somebody else to talk. Please. Any questions? Have I confused you? What was on your mind when you saw this, that it was going to be on the exchanges? What did you really want to know? Because I didn't know. Go ahead.
I have two questions. One is, how are the insurance companies how are their revenues from these patients versus normal patients that sign up? If it's not an exchange, are they making the same money? Are they paying out the same money per claim? Is it?
No, you can't look at that way. You can't look at it that way because it's an entirely different demographic population. These are people who are by and large, as I say, if they're working, they're working on their own, or they're working in a situation that is not typical of what the big insurers serve, for their employer-sponsored plans. So they're really different people altogether. And there's a large proportion of people who go in and out from Medicaid to now that exchange plans are available. Whether they go into exchange plans is a little unclear. But these are traditionally been people who've gone in and out of Medicaid. So they don't use health care the same way as the typical employer family, upper middle class, working for a big firm. It's a different set of circumstances. I cannot characterize the incidence of disease. One might have some suspicions about, the incidence of diabetes or something being higher in this population, but I don't know that that's actually true. One thing is true, though. This is a population that typically has not had a family physician. And so one of the things that we did see for the first couple of years, I don't know if it's still true, but for the first couple of years, we saw a big spike in people going to the emergency room. Why? They now had coverage. Why did they go to the emergency room? The answer is they didn't have a doctor to go to. Or they couldn't get to a doctor's office in the middle of the day because, mom was working and there was nobody, no other adult in the family or whatever. And so you waited until the kid got really sick, because it was always the kid that takes you to the emergency room. I've been there. And you wait. You hope that it's going to get better. It doesn't get better. Take the kid to the emergency room. Ideally, it's an antibiotic or something simple, and you're all set. But emergency room usage went up because now it was okay to go to the emergency room. Because I had this other kind of insurance, and it said I have the right to go there. Now, they had the right to go there before, but it was affirming in that sense. So I would guess that this is probably a lower margin business. I think that's the way I would look at it. I think it's a lower margin business. It was certainly a negative margin business for the first couple years. Is it a positive margin business now? Probably, but I'm not 100% certain about that. Insurance companies don't go in and out that easily. And they're smart. They realize that we turned a political corner with the ACA. We're never going to go back around that corner. And so they have to be ready for whatever the next move is, which will not be as dramatic. And so you're going to bide your time, and you're going to figure out whether you need to stay in a specific market or not. But are you going to leave the individual market? I don't think so. I think they're going to stay in selected individual markets across the country.